Good afternoon. Thank you very much for interviewing me. I'm Tariq Mughal. I'm a professor of medicine working in Boston at Tufts University and now also in Los Angeles at the City of Hope. My principal interest is in myeloid malignancies, in particular the chronic myeloproliferative neoplasms. I'm here today chairing the Myeloproliferative Neoplasms session, and I will be presenting some of the novel findings which epitomizes how the treatment paradigm for patients with myeloproliferative neoplasm has changed in the last decade in particular. So one of the focus of my presentation is how to integrate the genomic and molecular profiling landscape which is unfolding based on very large myeloproliferative neoplasm registries on both sides of the Atlantic, both in the US and in Europe, but in particular the efforts of people like Radek Skoda, who is based in Basel and has collated data on well over 3,000 patients, and others, of course. So the information garnered from this analysis is helping us to stratify newly diagnosed patients in a better way according to the risk related to the disease and also risk related to potential therapies. So collectively, when you look at these parameters, excuse me, you're able to come up with an algorithm which balances the pros and cons and helps you to select patients for particular therapy based on their mutational landscape. Now, it's important to recognize that a lot of this work is still in evolution. It needs to be validated by independent investigators as well. But by and large, based on the current information, we're already integrating some of this information in the clinics. As illustration, the BCR-ABL negative myeloproliferative neoplasms are driven typically by one of three driver mutations, the JAK2, carratuculin, or MPL. And we're now beginning to recognize the different contribution to the phenotype of the disease by the individual therapies. And if you look at the therapies, for example, ruxolitinib, which was approved about 12 years ago in the US and is widely used to treat both myelofibrosis patients and a patient with polycythemia vera, and it's in clinical trial for essential thrombocythemia, seem to work best for patients with JAK2 mutation. In contrast, if you look at the alpha interferon, it's possible that the alpha interferon may work slightly better in patients with the carratuculin mutation. So I think this is a very exciting time to be in clinical research in these diseases and see how the translational findings translate into clinical findings and then make their way into the clinic to help optimize the clinical outcome for our patients with myeloproliferative neoplasm. Thank you very much.